Hey everyone, welcome back to Pharmacy Made Easy. Today we are diving deep into gout, a common and painful condition that affects millions worldwide. Gout is a type of inflammatory arthritis caused by the deposition of monosodium urate monohydrate crystals in and around the synovial joint. These needle-shaped crystals form when uric acid levels in the blood become too high, a condition known as hyperuricemia. How does uric acid build up? Uric acid is an end product of purine metabolism. Purines are naturally occurring substances found in many foods and are part of an DNA base pairs. Under normal conditions, uric acid is excreted primarily via the kidneys and the GI tract. However, when the production exceeds the excretion, uric acid accumulates in the bloodstream and may crystallize in the joints, causing the gout. And the normal uric acid levels are in females. Normal uric acid levels are 2 to 6.5 mg per dl, and in the males it is 3.5 to 7.2 mg per dl. Values above this range increases the risk of gouty attacks, although some individual may remain asymptomatic. Now let's see epidemiology of the gout. Gout affects around 1 to 2% of the global population, but here is the catch. It has a striking male predominance with a 5 to 1 male to female ratio. It is a most common form of an inflammatory arthritis in the men and also increasingly seen in the older women, especially after the menopause. Now let's see the risk factors and demographics. The risk of developing gout increases with age, serum uric acid levels, and body weight. Men naturally tend to have the higher serum uric acid levels, and these level rises with the age. Certain ethnic groups such as Maoris and Pacific Islanders also show higher uric acid levels, increasing their risk. Hyperuricemia is officially defined as serum uric acid levels greater than 2 standard deviation above the population mean, which means the serum uric acid level that exceed 2 standard deviations above the population mean. Typically, that is greater than 6.8 mg per dl in most lab references. Gout can be asymptomatic, that means high uric acid but no symptom, or acute gouty arthritis, that means sudden severe joint pain, often with the swelling, redness, and the warmth. The big toe is the classic site, but ankles, knees, and elbows can be involved. Without treatment, attacks may recur and cause a chronic joint damage. Now, what triggers hyperuricemia? Let's look at two major categories. One is drugs and diseases. Drugs that raises the uric acid levels or alcohol, especially the beer, diuretics like thiazide and loop diuretics, cyclosporin, ethambutol, levodopa, niacin, pyrazinamide, low-dose aspirin, and theophylline. The above-mentioned drugs interfere with the uric acid elimination or increase its production. And the conditions linked to the hyperuricemia is diabetes, obesity, atherosclerosis, hypertension, kidney diseases, heart diseases, metabolic syndrome, some cancers, and the myeloproliferative disorders. If you are on these medications or have any of these conditions, keep a close watch on the uric acid levels. Why gout is rising globally? Gout cases are increasing because of longer life expectancy, rising rates of obesity, diabetes, and hypertension, global spread of the metabolic syndrome. Hyperuricemia is now considered a key part of this syndrome. Key clinical insight is, even though the high uric acid is linked to the cardiovascular, renal, and vascular diseases, most people with the hyperuricemia never develop a gout. Important takeaway is, there is no evidence that urate lowering therapy benefit the people with an asymptomatic hyperuricemia. Now shortly we are discussing about the diet and lifestyle factors, acute gout treatment, long-term urate lowering strategies, special consideration for the different patient group. Let's go into it thoroughly and step by step. We begin with the reality. Despite gout being a well-known condition, there is a lack of well-controlled trials and systemic reviews for many of the standard therapies we use today. First one is NSAID. NSAIDs are first choice for the treatment of acute gout attack. There is a standard and a full dose, then reduced by the half once the symptom improves, and eventually withdraw after a few more days. Side effects are more common in elderly patients and those with the renal dysfunction. Consider COX inhibitors like celecoxib or etirocoxib, and the proton pump inhibitors or misoprostol for the patient at the high risk of GI complications such as age over 65, history of GI bleed, those on the corticosteroids or anticoagulants. And the next drugs used is corticosteroid injections or oral options. For single joint attack, an intra-articular steroid, which means the injection given into the joints, is ideal. It provides rapid inflammation control, and it is especially helpful for the diagnostic purposes. The systemic steroids are used for the refractory attacks or when NSAIDs are contraindicated, especially in the elder patients or those with the multiple joint involvement. And the next category of drugs in the treatment of gout is colchicine, effective but limited by the toxicity. Colchicine can be highly effective. It provides a pain relief within 24 hours in 90% of the patient if started early. However, its use is limited due to the gastrointestinal toxicity, especially at the higher doses. GI side effects are often come before therapeutic benefit. IV colchicine is generally avoided due to the severe toxicity risk and is restricted to the hospitalized patient as an last resort. In modern practice, colchicine is not a good choice to treat an acute gout in many of the patients. Coming to the other drug which we used in this acute treatment of gout is uricase PEG-20, a newer option. It's not available in the Canada. This drug dissolves uric acid directly but carries a risk of immunogenic side effects. Before we dive into the individual drug, let's see the therapeutics tips. Start therapy early, the sooner the better. Don't stop or start urate lowering drugs during the acute attack. This may prolong or worsen the symptom. If prednisolone is used, consider higher doses like 30 mg daily for the beneficial effect. Now let's see the non-pharmacological choices, lifestyle and diet. Study has shown strong link between the diet and the gout. The risk factors include meat and the seafood, obesity, especially BMI greater than 30, beer and the liquor consumption. And the studies also shown that there is no increased risk of total protein intake, purine-rich vegetables, wine consumption. And the protective factors are low-fat dairy products. These shown a strong inverse association with the gout. The more dietary consumed, the lower the gout risk, especially when the fat content is low. Now, let's see the acute gout treatment in detail. Gout attacks are extremely painful. Acute gout treatment should begin as soon as possible. A single drug is recommended, which is either an NSAID or systemic steroid or a colchicine. In more severe diseases, combination treatment usually include colchicine with either an NSAID or oral steroids. If the gout attack is localized to one or more joint, an intra-articular steroid injection can be helpful. If an acute attack occurs in a patient using the chronic urate lowering therapy ULT such as allopurinol or febuxostat, they should continue the ULT during the acute attack. Topical ice applied to the affected joint reduce the pain and inflammation. Now let's see the treatment dosing, safety side effects and monitoring. And the dose of the colchicine is 1.2 milligram per oral. This is 0.6 milligram tablets followed by the 0.6 milligram in 1 hour. Do not exceed total of 1.8 mg in 1 hour or 2.4 mg per. If the creatinine clearance is less than 30 ml per minute, the treatment dose is same but do not give again for 2 weeks. For prophylaxis, 0.6 mg once or twice daily is given, and if the creatinine clearance less than 30 ml per minute, should be decreased to 0.3 mg per day in the prophylaxis treatment. And the colchicine is contraindicated if the patient is using the strong CYP3A4 inhibitors with an renal or hepatic impairments. The warnings include myelosuppression, neuromuscular toxicity including the rhabdomyolysis. If possible, do not use with cyclosporin, diltiazem, verapamil, gemfibrozil or statins as they increase the myopathy risk. And the side effects include diarrhea, nausea, myopathy, neuropathy, which is an dose dependent, and there is an vitamin B12 deficiency. The key points include start within 36 hours of the symptom onset for the treatment, wait 12 hours after the treatment dose before resuming the prophylaxis dose. There is also the increased risk of myelosuppression, GI and neuromuscular adverse effects in elderly with the creatinine clearance less than 30 ml per minute. Decrease the dose and monitor or use steroids as an alternative. Maintain adequate fluid intake. Coming to the next other category of drugs that are used in the acute gout treatment are NSAID. NSAIDs like indomethacin with the dose of 50 mg per oral 3 times a day until the attack is resolved, and the naproxen 500 mg per oral twice a day until the attack is resolved, and the drug sulindac 200 mg per oral BID is given until the attack is resolved. And the selective COX inhibitors like celecoxib at the dose of 200 mg per oral twice daily discontinue within 2 to 3 days after the attack is resolved. Important Points to remember during the treatment is avoid use in severe renal diseases because uric acid is renally cleared and the patient with the gout often have the renal insufficiency and see cardiovascular risk. Bleeding risk is lower with the short duration of use. Indomethacin and naproxen and Sulindac are approved for the gout. Other NSAIDs also can be used. And the other category of drugs that is used in the acute gout treatment is steroids, which are given per oral through the mouth, IM, intramuscular, intravenous, or intraarticular, or as adrenocorticotropic hormone ACTH, which triggers the endogenous glucocorticoid prednisone or prednisolone 30 to 40 mg per day given daily or twice daily until the attack is resolved. Then taper reduce dose by 5 mg each day over 7 to 10 days. And the other drug in the same category is methylprednisolone, which is given intra-articular if 1 to 2 large joints are involved, or the oral methylprednisolone dose pack is used. And the other drug used in the same category is triamcinolone. If 1 to 2 joints are involved, intra-articular into 40 milligram is given. If it is an polyarticular, which means many joints involved in the body, intramuscular with a 60 milligram can be given. And this is also repeated once or twice per every 48 hours. And the acute side effects of these steroids include increased blood glucose, increased blood pressure, insomnia, or increase the appetite. Intra-articular steroid injections stay localized and do not cause us the systemic side effects. Repeat injection treatment can cause the joint damage. Now let's see the prophylactic treatment. Chronic urine lowering therapy should be started in all patients with a gout who have experienced multiple or frequent gout attacks, have evidence of joint damage, or have a tophi, that is uric acid crystal, that form under the skin, or long-term gout. When starting the chronic urate lowering therapy, colchicine, steroids, or an NSAID should be used as an prophylaxis to reduce the risk of attack, which can occur when the uric acid is lowered rapidly, possibly due to the metabolization of uric crystals. The first line urate lowering therapy is allopurinol, a xanthine oxidase inhibitor. Blocking the xanthine oxidase inhibitor stops the production of uric acid and produces a non-toxic end product. Patient at higher risk of severe allopurinol hypersensitivity reaction, including a certain Asian group, should be screened for the gene HLA-B5801 allele prior to the use. Another xanthine inhibitor used is febuxostat, which is available as an alternative treatment option. Xanthine oxidase inhibitors titrated up slowly to lower the uric acid to a target levels of less than 6 mg per dl. Allopurinol is started at then low dose with an moderate or severe CKD. Probenecid is an uricosuric agent and a second-line treatment that can be used if the xanthine oxidase inhibitors are contraindicated or not tolerated, or can be added when urate lowering levels is not at a goal despite maximal dose of xanthine oxidase inhibitors. Probenecid inhibits reabsorption of uric acid in the proximal tubule of the nephron, which increases the uric acid excretion. It requires adequate renal function to be effective, which many patients with the gout don't, as it majorly occurs with the age above 40. Another option when the xanthine oxidase treatment is inadequate is lesinurad, a uricosuric that is taken with an xanthine oxidase inhibitor. Pegloticase is an recombinant uricase enzyme which converts uric acid to an inactive metabolite that can be easily excreted. Pegloticase is reserved for the severe refractory diseases. Now let's see the drugs used for chronic urate lowering therapy in detail. These xanthine oxidase inhibitors decreases the uric acid production. First one is allopurinol, which is available in tablet and then injection form. Start at 100 mg daily, then slowly titrate up until uric acid is less than 6 mg per dl, which means dose greater than 300 mg can be necessary and should be divided twice daily. If the creatinine clearance is less than 30 ml per minute, start at 50 mg daily, increase gradually to 300 mg per day. Allopurinol should be taken after a meal with food in the stomach to reduce the nausea. And the next drug is febuxostat. Start at 40 mg daily, then increase to 80 mg if the uric acid not less than 6 mg per dl at 2 weeks. Can increase to 120 mg per day if needed. And in the patients with the creatinine clearance less than 30 ml per minute, maximum dose is 40 mg daily. And the main warnings for this allopurinol is hypersensitivity reactions like including severe rashes and HLBA5801 testing prior to the use if the high risk, especially from patients as an Asian descendant. And do not use a drug if positive and in the conditions like hepatotoxicity, bone marrow suppression. And the side effects include rash, acute gout attacks, nausea, diarrhea, and increased liver function tests. While on the allopurinol, complete blood count, liver function test, and renal function test should be monitored. Allopurinol A can be used in the higher doses for the tumor lysis syndrome due to the high rate of gout attack. When beginning, urate lowering therapy used with the corticosteroids of 0.6 milligram once or twice daily or NSAIDs for the first 3 to 6 months. And the next drug is febuxostat. Start at the 40 milligram daily, increase to 80 milligram if the uric acid not less than 6 mg per dl at 2 weeks, and can be increased to 120 milligram per day if needed. And the patients with the creatinine clearance less than 30 ml per minute, maximum dose is 40 milligram per day, should be given. And the warnings for this febuxostat include increased risk of cardiovascular death compared to the allopurinol in patient with an established cardiovascular disease. Use should be limited to those who cannot tolerate allopurinol, example hypersensitivity, or if the allopurinol is not effective. And the contraindication is do not use with an mercaptopurine or azathioprine. And the side effects are rash, nausea, increased liver function tests, and arthralgia. And the other warnings include hepatotoxicity, possible MI or a stroke, gout attack, hypersensitivity, and serious skin reaction, including the HAS or TEN or a DRUS syndromes. Due to the higher rate of gout attacks, when beginning of urate lowering therapy, use with the colchicine 0.6 milligram once or twice daily or an NSAIDs with for the first 3 to 6 months. And this is the end of the xanthine oxidase inhibitors, which decreases the uric acid production within the body. Up next is uricosuric agents, which inhibit the reabsorption of uric acid in the kidney, which increases the uric acid excretion. The drug is lesinurad, which is available in the tablets 200 milligram daily in the morning with an allopurinol or febuxostat. If xanthine oxidase is stop lesinurad, only indicate if the creatinine clearance greater than 45 ml per minute, and if the creatinine clearance less than 30 ml per minute, it is contraindicated. The main warnings include acute renal failure, more common if used alone, only used with an xanthine oxidase inhibitors. And the therapeutic is use only with an xanthine oxidase if uric acid goals are not reached with an xanthine oxidase inhibitors alone, but keep hydrated. And the next uricosuric agent is probenecid, which should be started at 250 milligram twice daily and can increase to 2 gram per day. And if the creatinine clearance less than 30 ml per minute, avoid the use of this probenecid. And the main contraindications of this uricosuric probenecid is do not use with an aspirin therapy, blood dyscariasis, nephrolithiasis, that is uric acid kidney stones, and the child less than 2 years, and initiation in the acute gout attacks. The main warnings include with this probenecid is it decreases the effectiveness with creatinine clearance less than 30 ml per minute. And ACR guidelines says do not use if the creatinine clearance is less than 50 ml per minute, and do not use within G6PD deficiency. And the side effects are hypersensitivity reactions, hemolytic anemia. And the main point here is probenecid can be used to increase the beta-lactam levels by decreasing the beta-lactam renal excretion. And the next drug under the treatment of chronic urate lowering therapy is recombinant uricase, which converts uric acid to allantoin, which is excreted. Pegloticase is available in injection, that is 8 milligram IV every 2 weeks. And the boxed warnings include anaphylactic reactions, so monitor and pre-medicate with an antihistamines and steroid. Risk is highest in if the uric acid is greater than 6 mg per dl. Life-threatening hemolytic reactions and methanoglobinemia may occur with an G6PD deficiency. This pegloticase is mainly contraindicated in the patients with an G6PD deficiency. And the main warnings with this for the pegloticase is acute gout flare-up can occur upon the initiation. An NSAID or a colchicine should be given 1 week prior to the infusion and continue for at least 6 months. And the main side effects are antibody formation, gout flare, infusion reactions, nausea, bruising, urticaria, erythema, or pruritus. And the main key point here is do not use in combination with an allopurinol or febuxostat or probenecid due to increased risk of anaphylaxis. Now let's see the main drug interactions. Xanthine oxidase inhibitors. Allopurinol and febuxostat increases the concentration of mercaptopurine, the active metabolite of azathioprine. So do not use with mercaptopurine or azathioprine with febuxostat, and use caution combining these with an allopurinol and avoid or decreases the dose and monitor for the toxicity. Xanthine oxidase inhibitors like allopurinol and an febuxostat avoid the dose usage with an didenosin. Allopurinol and febuxostat can increases the levels of the didenosin, and the antacids decreases the allopurinol absorption. And the main drug interactions for the probenecid is probenecid decreases the renal clearance of other drug medications when taken together, including the aspirin. Do not take or use the salicylate concurrently with this probenecid. It also decreases the renal clearance of methotrexate, penicillins, cephalosporins, and carbapenems. Probenecid is sometimes used with an beta-lactam to increase the concentration of the antibiotic. This will increase the risk of adverse reaction. This is occasionally done with an penicillin when treating the neurosyphilis or other penicillin-related infections. Probenecid decreases the efficacy of the loop diuretic but increases the risk of loop diuretic toxicity. Now let's see the key counseling points for the colchicine and allopurinol. For the colchicine, at the first sign of an attack, take 2 tablets. Take 1 more tablet in an 1 hour. Do not use more than 3 tablets in an hour, and do not use more than 4 tablets in 24 hours. And do not take the second dose if you have an upset stomach, nausea or diarrhea, and they can also cause muscle damage. And the key counseling points for this allopurinol is they can cause mild or severe rash, liver damage, nausea, and take it after a meal to reduce the stomach upset. Higher doses can be divided. Drink plenty of fluids. Finally, we end this video with an enters critical period and an prophylaxis. Let's talk about what happens between the 2 gout attacks. Most patients will have a second gout attack within 6 to 24 months. Later, attacks are usually more severe, more frequent, and more polyarticular, meaning that they affect the multiple joints. The patient may show the signs of joint erosion, tophy, and even the asymptomatic crystal deposition during this phase. Importantly, 12 to 58% of the patients still have urate crystals in their synovial fluid during the symptom-free period. This phase is intercritical period and is best window for the prophylactic action. So there you have it. From the diet changes and the lifestyle tweaks to the powerful treatment options, managing the gout is not only possible, it's completely within your reach. Remember, early recognition, consistent care, and the health routine can make all the difference. If you found this video helpful, do not forget to like, share, and subscribe, and hit the bell icon so you never miss an update on your health. If you got any questions, drop them in the comments below. I would love to hear from you. Stay informed, stay healthy, and I'll see you in the next. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.